I'm so happy that we have again this year Judith Finley, Dr. Judith Finley, PhD. She is Director of Scientific Affairs at the Binding Site San Diego. They're the group that created the free light chain, and they have a new test, the heavy light, which I know a lot of people want to learn about that. Judith Finley, Dr. Finley writes a column for our newsletter called Lab Light every month. So we are very pleased of her involvement with us, not only in speaking and doing a great job as she always does in terms of explaining lab results and lab tests. And as you see, she has already been going around explaining lab tests, and she'd be willing to do that after her presentation for those of you who have brought your lab results to talk with her. So without further ado, Ms. Finley, please.
I'm going to see if I can get this to work here. Now, can everybody hear me all right?
Yes.
I'm going to try to project throughout this whole talk, and if you can't hear me, just raise your hand because maybe my voice has dropped down. Can you hear me okay? Okay, so if you can't hear me, if I start talking too quiet, raise your hand and I'll pop up the volume. This is a little easier for me to be down here talking with you. So like Anthony said, the title of my talk is Understanding the Free Light Chain, Serum Free Light Chain Assays or tests. And we also call this free light. And then we have a new test we call heavy light, which you all have specifically asked me to come and discuss. So I'll talk about both of those tests. And now I have a safe harbor statement that we have to put on our presentations. Some of the subject matter contained and addressed in the following presentation may involve off-label or forward-looking use of the free light and heavy light kits. You're familiar with this type of thing from off-label use of drugs. Sometimes that gets described in courses, and that is not, we cannot, as the binding site, as such, no off-label use of free light or heavy light can be supported by the binding site. So physicians can use our tests how they see fit, but we can't promote the use of certain aspects of the free light test, and we can't promote the heavy light test at all because right now it's not actually approved. If anyone has questions about that, they can see me afterwards about what can and can't be done.
Excuse me, can I just offer paper if anyone needs paper to take notes?
Does anybody need paper
Just
to take notes? And the presentation is actually on Anthony's wife's computer, so if anybody needs that, he's got access to it, he can send it out.
I'll send it to anybody who wants it. I will email it to you.
Okay, so everybody could get a copy of it for your use. So what I'm going to talk about today is, here's an outline of everything I'm going to discuss with you. I'll talk a little bit about background, so we all get us up to the same level, because I know some people, why don't I start actually asking people, how many people have never even heard of the free light or serum free light chain test? Okay, so a couple of people down here that don't have any idea about it. How many people have heard about the test, but they're not really sure why it's used or what it's for? Okay, we got a couple of people like that. Okay, how many people could explain to the other people exactly how the free light test is used and all the ins and outs? Okay, so that's why we're here. There's a difference of knowledge between people. Some people don't know much, and some people know quite a bit, because I've been here a number of times. So we want to make sure that everybody, that's the point of the group, is the more everybody understands, we can help each other out. And when I come to these groups, I learn a lot I didn't know about the Black Swan Initiative. So we're all learning here, and it's really beneficial for all of us. And thanks very much for sharing that, Anthony. So I'll bring us up to about the same level. The other thing I wanted to point out is, if you're new and you haven't heard any of this before, don't expect to understand everything I say in this entire presentation all at once, because it may be too difficult. But just listen to it and pick up whatever you can, because through repetition and hearing other people talk, you'll begin to understand the whole thing. So there are a number of different tests used to assess multiple myeloma besides the free light test, and I'll talk to you about those. I'll talk about at length about some of the advantages of the free light chain test. And then it's called the serum-free light chain assays or serum-free light chain tests. And then the brand name is Free Light. That's our brand name for the test. And then I'll talk to you about some practical considerations. Then I'll talk about some new tests that we have called Heavy Light that are out in Europe, but they're not yet approved in the U.S. yet, but they're being used for research in the United States. And then I'll summarize everything. So as most of you probably know, multiple myeloma is a cancer of the plasma cells. So the cancerous plasma cells accumulate in the bone marrow and cause the symptoms of the disease. And this can be increased infections, kidney damage, anemia, and bone damage. And we can use testing to monitor the disease and guide the therapy. So plasma cells are generally in the bone marrow. So the bone marrow is a soft blood-forming tissue that fills all the cavities of your bone. And different cells are produced there. All the blood cells are produced there. Red blood cells, white blood cells, platelets, for example. And one type of white blood cell are the plasma cells. And they're shown here in this photomicrograph. They're these large purple cells right here. So the plasma cells produce antibodies. These are also called immunoglobulins and light chains. So these are the intact, we call them intact immunoglobulins or antibodies of Y-shaped structure. And then they produce the free light chains here. There's two different types of them, kappa and lambda. And each cell either produces kappa or lambda, but the cell will not produce both types of light chains. So the antibodies are made up of heavy chains and light chains. So not only are there free light chains, but there's actually light chains bound or are part of the antibodies. So this is another diagram of antibodies or immunoglobulins. And one thing I wanted you to take away from this slide is that each patient's monoclonal protein is different. So while each person is producing a certain type of immunoglobulin or light chains, each person who has myeloma, it can be different. And the reason for that is the antibody has a constant region and a variable region. And the reason there's a variable region is these bind to different molecules. That's their purpose, to bind the molecules, and then the rest of the body can use it to eliminate pathogens. That's the normal role of an antibody. In a myeloma patient, there's a lot of this antibody being produced, and so it's not serving its normal function. But the reason it's different is you have a cell that's producing one type, and that's why it's different for every patient. And that's why patients have different symptoms, because just because you all are myeloma, you could be all myeloma patients, but you all have different symptoms and different disease progressions because this monoclonal protein, in large part because the monoclonal protein is different and the cell producing it is. There are some people that have, there's another disease that's related to myeloma called AL amyloidosis. So some people might show up your group that have AL amyloidosis because it's similar to myeloma. And there are people with myeloma, and there are some people that are lucky enough or unlucky enough, if you look at it, that have both of these diseases. So it's good to keep that in mind. This slide shows a diagram of what happens in a normal person's bone marrow versus somebody that has myeloma. So in a normal person, you have a variety of different plasma cells producing a variety of different whole antibodies, and you can't see it there, but there's one light chain up here. A small number of light chains are normally produced. In normal people have some free light chains. But then during the cancer process, one of these cells will become cancerous and start to grow and overgrow large sections of the bone marrow, and they'll produce one type of antibody. For instance, this person has a cell that expanded and produced IgG kappa. So it's producing too many IgG kappa molecules, too many light chains. And so the excess of this production of cells and the proteins are what causes the symptoms of the disease. So this is a slide that was made by my supervisor that diagrams how myeloma therapy works. So you have the plasma cells producing the antibodies and the light chains. And then you get therapy. And the therapy attacks the plasma cells. And then kills the myeloma cells, so there's fewer myeloma cells, and you get fewer myeloma cells, and you have fewer light chains and fewer antibodies. So we're able to measure the amount of these light chains and intact immunoglobulins in your bloodstream with the free light and other assays. And so when you get therapy, if the number of them goes down, then we know that the therapy is effective and these plasma cells must be being killed off. Now there's a number of different tests used in multiple myeloma besides just the free light test, and they're indicated here. The first one is serum protein electrophoresis, and unfortunately it has a number of different acronyms or abbreviations that are referred to, SPEP, SP, and so forth. It measures the M protein concentration in grams per liter. So this is the monoclonal protein concentration. You've probably heard people talk about that. There's also a test called immunofixation electrophoresis, and fortunately this one only seems to have one abbreviation, IFE. It identifies what type of M protein you have, and this becomes important for your physician, your treating physician, and gives them some ideas about prognosis and so forth. And it is a qualitative assay. It's either plus or minus. It's there or it's not there. There's no gray zone in this type of test. Then we have the serum free light chain test. We abbreviate it SFLC, or we call it free light, and it measures the light chain concentration in milligrams per liter. So there are two types of free light chains, kappa and lambda, and we actually made two kits, one that tests the kappa and one that tests the lambda free light chains. And the free light test measures the free light chains in your serum. So I can't see that very well. The advantages of the free light test here, it's a very sensitive assay. You can't read that. It's very sensitive to the detection of free light chains. It can, in some cases, give earlier detection of response to treatment than some of the other tests, and in some cases, give earlier detection of relapse. And I'll show you some examples of that. So the tests that measure antibodies and light chains are shown here. So you have the plasma cell producing antibodies, and these are measured by serum protein electrophoresis and immunofixation electrophoresis. Then the plasma cells also produce free light chains, and these are measured by the free light chain test. So sometimes your physician will talk about the M spike or the monoclonal spike or the monoclonal protein. That comes from serum or urine protein electrophoresis, that test. So this is what happens, this is what your physician is looking at when they see a normal serum protein or serum or urine protein electrophoresis here. This is the gamma region, which is the area that they're looking at, and you should see a rounded kind of small peak. But in a person with myeloma, they have a large peak here and a dark staining band from the electrophoresis. So that's why they call it an M spike. And this is how they actually measure the amount. Because they actually take this gel and scan it just like you would on a flatbed scanner. And they record this line, and then how high this line is says how many milligrams per liter are in there.
What's the relationship between an M protein and an antibody?
This is the question is, what's the relationship between the M protein and the antibody? The antibody, or the light chain, they electrophorese on the gel, and this is generally where they come. So this is a measure of the antibody that's there, but it's a little complicated because the light chains can also be in here as well. So this peak is, they call it a paraprotein, because it's a protein that's not supposed to be there. This is what it's supposed to look like. And then when you have something else in here, this is an unusual signal. So, and the immunoglobulins are in this region. This is called the gamma region because it's where the gamma globulins, where the antibodies normally should be, and usually have a variety of them here. And here you've got one type, and there's a large amount. Okay. Question?
The M spike ideally should be 0, and the kappa thing, everybody has kappa likes, normal people, and we can get into the normal range. I forget what the numbers are, but
I had that.
okay. Is that what I said true?
Well, for the most part, you're right. This peak if you have a normal person, you go here, so you'll have a peak. Because this is all the antibodies in your bloodstream. You should have antibodies in your bloodstream. A normal person would have a peak that looks like it's a small peak that's diffuse. And the myeloma patient has a very large peak that's dark. So this is like one protein is being overproduced. Here you have many small amounts of all the different antibodies. So for the SPAP, you'll never go to zero here. You'll go to what they call a normal looking pattern. And that's kind of a judgment call, because it doesn't always look as pretty as this. For anybody who's a scientist in the audience, they know that this is a textbook example. But the reality is, these look a lot different. And telling the difference between normal and disease is a job for a pathologist and somebody who has a lot of experience looking at these.
Being an organic chemist, I haven't done electrophoresis, but I've done gas chromatic, I have liquid chromatic. And they basically all have the same pattern. And judging where the baseline is very different.
Yes, that's exactly right. Because this doesn't always look so pretty. This is the textbook case, and that's where the complicating factors come in for people that have a lot of experience looking at these to say, yeah, this is normal and this is disease. Because obviously this is, we can tell the difference because it's a textbook example. Well, what if this peak is only half as high? What is that really? Or if this, hopefully when you get treated, this peak goes down. How far down does that have to go before they consider you normal? That's where the complicating factor goes in, and it takes a lot of time and expertise to figure those things out. But you've got the right idea. The difference between this and this is pretty dramatic, and you're trying to get from here to here.
What would that M spike be? Do you have an estimate of like 1.3 or?
That's a good question that I don't know the answer for. Would this be like 3 grams or grams per liter or whatever? I don't have that number here for this data. But in your lab report, you might actually see a picture like this. And it might below say 3 grams per liter or 5 grams per liter. So look on your laboratory report.
What,
Well,
they
they
always give me a decimal
They just give
number.
you a number.
They don't usually, some of them I've seen the picture, but usually they just give you the number. So when you get your lab report, you'll see something like SPEP or SPE, and there'll be a number, gamma region, 3.1 grams per liter. And there should be a high next to it or M or something telling you that. Yeah, we can look at it if you want me to look at it. Okay, this one is serum testing specific for 3 light chains, and I can't remember what we have chains. What we have here. And then this is the number of this is the units are not showing up at all here. This is the normal ranges for the 3 light test. All my reds are dropping out of the screen for some reason. These units are milligrams per liter, and these units are milligrams per deciliter. So different laboratories report out in both of these units. So they'll use one unit or the other. You have to be careful of units. So if you remember your high school decimal, part of the high school decimal arithmetic class, to move it, to change the units, milligrams per liter to milligrams per deciliter, just move this decimal point over 1, and you'll get this value here. So it's a difference of a factor of 10. So be sure and look for that. I've got another example in here. And for the kappa, the normal range is 3.3 to 19.4 milligrams per liter. For lambda, it's 5.7 to 26.3 milligrams per liter. And then the ratio, just take the kappa divided by the lambda, and that's the ratio, 0.26 to 1.65. And you should see these ranges on your laboratory report. Most laboratories are using our ranges. So if you look at your lab report, you should see this set of 3 numbers.
Oh, I'm sorry, I was trying to get the
Yeah, if you,
lights out.
I don't know why the red is just completely being wiped out. Anyway, so it's very sensitive to detection of 3 light chains because it's in the milligrams per liter instead of the grams per liter like your SPE. So for early detection, I'll talk a little bit about early detection of responsive therapy in the next slide here. So this shows 3 light detecting a response earlier than seroprotein electrophoresis. So this is a patient with IgG kappa, multiple myeloma, and the blue here is their SPEP IgG chain in milligrams per liter. And the patient comes in, they start their chemotherapy here, and if you were to just look at the SPECT value, you think, wow, for 50 days, nothing's really happening. But if you look at the free light thing, after 10 days, wow, something happened really quickly here. So that's one of the advantages of free light, is it changes quickly in response to therapy many times, much more quickly than SPECT. And the reason for that is this is a much smaller molecule, and it's metabolized more quickly by the body than this in an intact immunoglobulin is. So it's got a basis in biology.
I have a question. On a normal blood test, which happened to be, they caught someone. Which one of those would have been the one they caught that was hot?
That's a good question. He had a normal blood, he just had a routine blood test. And he's saying, what do you think, what test was it? Well, I'm not sure. I'd have to take a guess. My guess it was serum protein electrophoresis, because that is a test that if a physician suspects a monoclonal gammopathy or a plasma cell disorder, which myeloma is from your symptoms, then the first thing would probably do is order the serum protein electrophoresis test. And it's pretty definitive, because if you have that M spike in there, they know that you have a monoclonal process going on most likely. That's pretty definitive for a plasma cell disorder. So my guess it was the serum protein electrophoresis. Sometimes though it's other people have increased protein in their urine, and that's what led them to it. So it depends. You can even ask your physician, hey, well, was it that made you
I did it, but I didn't understand what it was.
Right. That's why you're here, which is good. So that's what I mean by sometimes you have to keep asking the questions, because things make more sense. The more you know, the more it makes sense.
I had a question. Some people have higher lambdas and normal kappas. Some people have higher kappas and lower. Why? What does it mean?
Yeah, what does it mean? Well, yeah, if some myeloma patients have an elevated kappa above the normal range, some people have elevated lambda. What does it mean? It means, remember how I said the plasma cell will only produce kappa or lambda, but not both. So what happens when you have myeloma is one cell starts overgrowing, and that one cell, they call it a clone, keeps reproducing, and it only produces either kappa or lambda. So it means the one cell that you have overproduced and say it's kappa, that means that we know that the one cell you had that started to overgrow was producing the kappa light chains.
Would you say yes to the question, and it could be environmental or genetic?
Yes, yeah, the cause for myeloma, you're asking, could be genetic or environment or both. A lot of times it's both.
I'm sorry, excuse me. Let's hold our questions until after her presentation so she can give you the presentation, and then you can ask as many questions as you want, okay? Go ahead, Judith.
Okay. Okay, the last one is earlier detection of relapse. And here's a picture of what that might look like. Free light detects relapse earlier than IFE in this particular patient. So what you see here is, this is the lambda free light chain in blue, and the immunofixation electrophoresis in green. And this is the number of months since transplantation. So transplant is a method that's used many times. Many of you are pretty aware or probably even had a transplant, a way of treating multiple myeloma. So they took this patient, they got a transplant, and they started following with the free light assay and with the immunofixation electrophoresis. And with free light, you can see the values of the test was going up on month 15. Basically, 70 is higher, then month 19 is higher. Immunofixation electrophoresis is still negative. So remember I said immunofixation is a qualitative attribute. It's either negative or positive, one or the other. Then immunofixation, all of a sudden here it's positive, and the free light's higher. And free light continues to rise, and the immunofixation is positive. So what does this mean for this patient? Free light chain levels started increasing 4 months before the immunofixation became positive here. So the free light was telling the physicians there's something going on before they would have seen it with immunofixation electrophoresis. So that's just an example of how free light can be used. Now, this is a slide that talks about monitoring therapy with serum free light chains. So I had someone, many times I have patients asking, well, I've got my free light chain values are fluctuating, they're changing. What does that mean? Well, this is kind of an illustration looks like for this patient. This is actually an amyloidosis patient, but it's still helpful because they're being monitored with free light. So this is the lambda free light chains in milligrams per milliliter, and here is the values here. They start up here around 140, and these are the normal ranges, slightly above 20 and slightly above 0, you can see here. They start out very high, and they had a stem cell transplant, and then they went down, the free light dropped into the normal range. Then it started coming back up. They got a different therapy, and it dropped almost into the normal range. And then it came back up. They got treated for a while with thalidomide, and their values were higher than the normal range, but they're not as high as when the patient started out. But they're still fluctuating. So people's values can fluctuate on therapy. That's something your clinician is very aware of, and they know they've seen this a lot before. So then, and the other thing I want to point out is this starts out 15th of June in the year 2000 and goes all the way to 2006. So this is a long period. This is a 6-year time period. And so then this patient goes off thalidomide, and their values start to rise. They got a different therapy, but then dropped them down again. And then they started to rise again. And then they got bortezomib. And this drug dropped it all the way down into the normal range, and it stayed down while they were on this therapy. So that's an example of what it would look like to be treated on myeloma, and your free light chain values can fluctuate. And your physician is following that, and it helps them figure out how well your therapy is working. So to go through these again, the advantages of the free light test, it's a serum test that's specific for free light chains, and you know that's really important when you're following myeloma patients. It's very sensitive for detection of free light chains. It can lead to early detection in the response to treatment. It can lead to earlier detection of relapse. In many of these instances, free light can be useful. So now I'm going to talk a little bit about lab reports. I'm going to social diagrams here, and then I can talk to you about them afterwards about your specific case. So this shows an example of units. Units are important. This shows an example of why that's true. So this is a person that got their free light tested in May, and you can see that their kappa free light chain is here, and they had 38.6 milligrams per deciliter, and it's above the normal range. So they're myeloma patient. Then they went July, and they went to a different laboratory. You can see the label of the test free kappa plus lambda light chain is different here than it was up here. So it's clearly being tested in a different place. And then they have 303, and that's high still. The units here are milligrams per liter, so they might think, oh my goodness, I've gone up a huge amount. But then if you look at the units, you say, oh no, it's actually better. Because if you take 38.5 milligrams per deciliter and convert it to milligrams per liter, it's really 385. So they actually come down. So it's good to look at these very carefully, look at the units, and also look at the normal ranges. This normal range is different from these normal ranges by shifting the decimal point over this one. Otherwise, all the numbers are the same. So that's one thing to keep in mind. There's a lot of things to look up on the lab reports. The value, the flag, and the normal range. Those are all important to look at. There's a lot of information in there. So what are some of the practical considerations for the measurement of free light chains? Well, there is laboratory variability when these tests, all tests have some laboratory variability. So laboratories spend a lot of time making sure this is consistent, and they make sure they know what their variability is in their particular laboratory. There is biologic variability for free light, and it depends on a normal person is different than a person that has myeloma, than a person that maybe has older myeloma, and it could change. And we don't have all these things nailed down yet, but we have some idea that we actually know for sure that the clinical changes are much greater than the biologic variability and the laboratory variability. And clinicians are very familiar with this part of it. So for laboratory variability, absolute values in the serum free light chain assay can vary from lab to lab. So there's some differences from one lab to another. And some of the reason for this is there's different chemistry instruments that are used in the laboratories. And we have to make a different kit for each instrument that the laboratory runs. So it's hard to make those exactly the same. And then, of course, I talked to you already about there's normally variation between different labs, even if they were running the same instrument.
I would say there's even differences month to month with the same lab.
Absolutely.
Baseline of the gamma.
There's absolutely, you're absolutely right. There's differences, there's so many differences you don't want to think about it. Because if they run the test 3 times all at once, that's one kind of variability. Different technicians running it can have different variability. 1 month, day to day, month to month, week to week. And that's all carefully controlled by your laboratory. They spend a lot of time on that. So they really know what it is.
I was talking to my oncologist, and he said, for example, a 2.12 Iemmsg can be the same thing as a 2.20. The baseline, depends on where they draw the baseline.
Right, and so we actually have confidence, we call them confidence intervals. So we say your value is 2 plus or minus 10%. So we don't know that it's exactly 2, but we know it's not 10.
Right.
And that's what's important, is clinically the difference between 2 and 10 is really important. The difference between 2 and 2.1, clinically that's not important because we really can't measure the difference. So that gets into the whole analytical chemistry, if you will. And that's a field that's interesting to me. You probably, but not for many other people, except for the difference between clinical. And that's usually really big. Questions about?
You had an example of 10% variation. Is that a standard for all tests, 10%, or maybe it's higher for urine protein or what variation?
That's a good question. Is 10% standard for all laboratory tests, or is it it varies greatly among tests and labs, and how they also have different methods they use to do things.
I'm sorry, please, hold your questions. Let her finish. Write down your question. She'll be more than happy to answer.